So at ESMO 2017, we saw the updated independent review of CABOSUN data. And this was important because some people were concerned when this was presented last year from the Alliance Cooperative Group that perhaps in an uncontrolled radiographic setting of investigator assessments, some of this data might be somehow biased one way or the other. This was not a blinded study and whatnot, and this was done in largely a community setting. And frankly, the results were quite astonishing. By investigator assessment, we had a 46% objective response rate for cabozantinib in an intermediate to poor risk patient population versus about 20% for sunitinib, so a fairly dramatic difference between those two, as well as about a 3-month difference in the progression-free survival. So I think those results caught some folks by surprise. In the past, when we've compared agents to sunitinib, we've seen relatively equivalent results, such as with Votrient or pazopanib. And so I think people were a little bit surprised by these results. And so the independent review was much anticipated, and I think very reassuring to see that it very much was consistent with what the investigator assessments are. That's important for 2 reasons. One, because I think it adds another layer of validity to this data. And 2, because I think it also gives us comfort to know that our assessments as clinicians in the field are pretty accurate overall. Lastly, toxicity was an issue with both drugs. These are multi-targeted inhibitors that carry with them risks, including diarrhea, fatigue, hypertension, and other physical manifestations from the drug. They were fairly balanced overall in both the incidence of severe toxicities and overall toxicities. And we saw, again, a similar number of patients that were able to tolerate this drug until disease progression. So overall, I think this suggests that cabozantinib is a very attractive frontline agent for the intermediate and poor risk patients that we might otherwise treat with sunitinib. Now, the final question might be, how does that fit with the Ipi-Nivo data that suggests that that also is an active regimen for this intermediate and poor risk patient population? And I don't know the answer to that. I think that's going to require further studies. And I think some of those studies should compare those regimens head to head. And I think some of those studies ought to look at those regimens both in terms of combinations together or in sequence. So we're excited in the field of kidney cancer. I think ESMO 2017 has left us with more to do. But it's great to know that we have now multiple treatment options for a patient population, particularly that intermediate poor risk, where we really need them.